So the take-home message that we have to have a better, very good oncology center of excellence when we want to implement new techniques. There is a need of better reporting optimization. Hypofractionation versus accelerated hypo is still in practice. PBI would replace whole breast radiotherapy in practice. 5 versus in 5 weeks or in 5 days or in 3 weeks, the fast and fast forward in practice. Effective communication for all members of the team treating the breast cancer patient is impacted. By this I end the radiotherapy talk, and never forget the NCCN guidelines. This is some selected contouring system. What about the cancer cervix? For the cancer cervix, the issue is that, of course, in stage 1 we have up to 96% survivorship. But for stage 4A, which is a locally advanced disease, and stage 2, we have a variety from 15 up to 87%. So definitely there's some patients who need some genetic markings or genetic profiling. Why do we have in stage 2 a 65 and an 87? All of patients have been treated in the same. Concomitant chemoradiation, we all know it is the standard of care. But why do we have this diversity? So, as I said, the genetic imprint, I think, is the future for the patients. And this is, we all know that in the past, radiation for the cancer service, 2 components, the central component and the peripheral component. Sorry for this basic knowledge. Para-aortic lymph node irradiation also for radiologically or pathologically positive para-aortic lymph node, prophylactic in high-risk patients not receiving chemoradiotherapy. And from the 2D radiotherapy, we learned in the past with the lymphatic trapezoid how to shape our 2D fields. And these are selected publications about the para-aortic radiotherapy. And definitely in 2004, addition of chemotherapy was better than extended field, but the extended field was not studied concomitant with chemotherapy. And all we know that 15 to 30% of patients with advanced cancer cervix will fail in the para-aortic. So if you are intending to treat the para-aortic, you should do this with IMRT or VTS. Definitely, you'll be having less gastrointestinal toxicity, and the local regional recurrence definitely will improve. So patterns of regional recurrence after definitive radiotherapy. Okay, 5 minutes. I'll be finishing in 5 minutes. The majority of failures were marginal. Most of them were above the field of 2D, and there was significant geographical miss. And this was a study done in 2013. The volume drawn in red is the volume in 3D. So, having 10 minutes? I'll try to stick to 5 minutes. So 3D, who will go with 3D with the cancer cervix? Of course, all of you, because the 2D, we have, at least in the craniocaudal measure, we have a miss of 3 centimeters cranially, and we have a miss of 0.27 centimeter laterally, and posteriorly, and anteriorly, you might be having a miss of 1 centimeter. So the 3D should be done for all cancer cervix patients. This is a practice change. And this is to show you that the volume receiving 95 and the 50 and the D mean to the bowel and D mean to the bone marrow definitely were statistically significant while you're using CT-based treatment. Empty or full bladder? Who would go with an empty and who would go with a full bladder treatment? Okay, thank you. But simulation is a snapshot. Unless you do an IGRT on a daily basis and make sure that your bladder is the same 100 cc or 120 cc, so it is very subjective. It is very subjective. And the patient by the 3rd and the 4th week be having cystitis, so he will not be able to control having a full bladder. But yes, theoretically, you should be having a full bladder because it will move your bowel away from the treatment field and it will compress the rectum. Potential use of IMRT, reduction in acute small bowel toxicity, prevention of late-term anorectal GI and gene dysfunction, reduction in acute hematological toxicity with bone marrow sparing, and simultaneous extended field plus or minus chemotherapy. You should go with IMRT. This has been shown by Professor Ahmed. Yes, some nice pictures about sparing the marrow, about reducing the dose to the critical structures, the IMRT will reduce the small bowel by 50 to 67%. And third, 30% of your patients will not need antidiarrheals because of limiting your dose to the small bowel, which is good, quality of life. The suggested potential, again, is they can heighten the dose to the pelvic lymph nodes if present, I'm sure, and post-operative patients with residual central disease, if they are not fit for interstitial brachytherapy. So there is room for IMRT and VMAT in cancer cervix. Yes, I have here with me my dear colleague, Dr. Sandy. She has been working on brachytherapy in Denmark, and she is a pro brachytherapy, and we are all pro brachytherapy, but we don't have except 2 brachytherapy machines in Egypt. So how can we accommodate all the cervix cancer patients? Unless we have brachytherapy beside the external beam, instead of traveling and extending the treatment duration, and we know that the overall treatment time is an adverse effect. So if you have a VMAT or IMRT, you can replace it, and it's an open way for discussion and an open way to do a phase 3 trial. So because of limited resources, you can use some practice change. The caveats of the IMRT, of course, we said the machine and treatment capability, the workload, extensive physics manpower, demobilization, the contouring, from 2D to the simple, again, simulation 5 minutes, to contouring and RTVG consensus and Jack Istro in 2006, very robust contouring guidelines. It takes a lot of workload. And concerns with the integral dose and second malignancy, we need some time. These are 8 studies, definitely retrospective studies, toxicity comparing IMRT to RTT technique, definitely IMRT is better. Comparison of nodal boost, the IMRT plan gave the best bladder and bowel toxicity. We can see in the down in the graph, in blue, which is 80 and 90, it is barely hitting the intestine and not touching the bladder. But if you are going with a 4-field plan or a parallel opposed pair, definitely you are hitting the bladder and the intestine. For the brachytherapy, the practice change have been since 2006. You have to follow the Jack Istro, and you have to move to a T2 weighted MRI fusion imaging, not CT scan. This is some pictures to show you how you have to delineate your patients using the MRI. All the lymph nodes. And standard of care now is to use IMRT in the post-operative setting of cancer cells. Definitely. It's an RTOG study. IMPT have been showed by Professor Auriti. And whether you're using IMRT with FDG, a PET scan, all of the new technology would add advances to a proper GTV delineation and a better organs at risk toxicity, less toxicity. Okay? This is how can you definitely boost with the PET scan and iliac lymph node. If we go for the brachytherapy, I'll go very fast. From the 2D, this was a point-based dosimetry. It was not a CTD-based dosimetry. And there's no optimization, no dose escalation was possible. That's why we moved to the Jack Istro 2006. And these are the recommended high-risk CTBs and GTBs. And the ICLU 38 reference points in star, you can see in the bladder, it's opposite the Foley. But the areas that was found to have a very high dose is the areas in green and orange and red, which are far beyond the ICLU 38 definitions. So this is again a practice change where we find dosimetrically and from the physics point of view where do we have a high dose, and that's why we should constrain the doses to these areas. Using CyberKnife and boosts have been also said before, and hybrid intracavitary interstitial is another practice where you can decrease your overall treatment time, incorporating brachytherapy as early as possible. At present, the dosimetric benefits of IMRT have concentrated in delivery of a boost to regions of the central boost to patients not suitable for brachy, so IMRT is an alternative. SIB to the target or affected lymph nodes, head, and autofractionation has the advantage of shortening the treatment time. The role of potential benefits of IMRT have been established in the RTOG 0418 in the post-operative setting. Advantages of bone marrow sparing, very nicely using the PET and the MRI inspect, and these are early results are promising. The future, as I said, genetic variability, there was no consistent association between the single nucleotide polymorphism and type of radiation toxicity, because type of radiation is different, and the dose is different, treatment volume is different, fractionation is different, the use of concurrent chemotherapy is different. So the research in this area is just beginning. The proton beam, this is from the clinicaltrials.gov. They are accruing patients, and this is a case scenario. What will you do with a patient who have a pelvic kidney or a pelvic transplanted kidney? Will you go with a conventional external beam or brachytherapy? Definitely the dose of the kidney will be very high. So unless you do a VMAT and a cyberknife boost, these are where new technologies can give an asset, especially if you have an incidental finding pelvic kidney, congenital, or if you have a patient who have a transplanted kidney. And this is very important, as we said, individualized treatment. So these are the currently going trials for the selected applications. And the transplanted kidney in green, of course, we having a very good dose. And at last, I'd like to thank you, and I hope that this presentation was useful.
Thank you, Professor Kapteni, for the nice lecture and for the effort done at your summary. And I think we are going to postpone the questions to the end of the session. And now I'm presenting Professor Khalid, Professor of Radiation Physics at Azhar University, for presentation of cases of the IMRT and the breast and gynecology. Go ahead.